but at the School of Data Science. And we're delighted you could join us today. So this, of course, is the panel on data and biomedicine, but specifically we will be talking about global infectious diseases. And so we'd like to acknowledge the co-organizer of this event, which is the Global Infectious Diseases Institute. And let me introduce our panel. So I specifically actually like to thank Allison Chris, Dr. Allison Chris, for helping to organize this and pull this together with me. Dr. Chris is the director of the Global Infectious Diseases Institute. And then also on our panel, and who will be speaking to us today, are Dr. Kathleen McManus. So Dr. McManus is assistant professor in medicine, specifically in the domain of infectious diseases and international health. Her research focuses on the optimization of HIV healthcare and outcomes. And then we have Brian Lewis, Dr. Brian Lewis, who is research associate professor in Network Systems Science and Advanced Computing Division, joining us also from the Biocomplexity Institute. So very exciting. And Dr. Lewis's research is focused on the understanding of transmission dynamics of infectious diseases within specific populations. If you've gone to previous panels, you probably already heard that sort of the framing question of all of this, and our goal by the end of the session is to address the question of how UVA is uniquely positioned to make a significant impact of research at the crossroads of, in this case, infectious disease and data science. So that's something we kind of like to keep as our framing question. And at this point, I'd like to invite Kate, Dr. McManus, to tell us a little bit about what she does.
Yeah, I want to thank both of you for the opportunity to talk today, and I'm excited to hear the conversation that ensues after we give our brief introductions. So as was mentioned, I'm an assistant professor in infectious diseases and international health. And there I'm a physician scientist, so I spend about 25% of my time, 25% of my time seeing patients, both general medicine, infectious diseases, and then also specifically people living with HIV in our outpatient clinic. And then 75% of my time is spent doing research. So I've been fortunate to be funded by many different institutes or groups such as the Agency for Healthcare Research and Quality, THRIVE, the Translational Health Research Institute of Virginia, the NIH through the National Institute of Allergy and Infectious Diseases, and GIDI through the 3CABS program here at UVA. And I think that, I think one of the big themes that I'm learning early on in my career is how important team science is, how important it is going to be to have physicians who know how to speak the language to talk to data scientists, and data scientists who know the language to talk to physicians. I think that those partnerships really can't be undersold. They're going to be the key to these complex questions that we want to answer. So some of my work, I look at quantitative health outcomes related to healthcare policy changes. So here in Virginia, when we weren't going to have Medicaid expansion, Virginia Department of Health did some very innovative work where they actually decided that they would offer to buy health plans for people living with HIV who have low incomes. Previously, the government would actually buy them their medications, and that can cost up to $10,000 per patient per year for the state. If you have private insurance, that actually costs about $40,000 per patient per year that the health insurance picks up. So these are high-cost diseases that are terrible for the individual, and then also have a lot of public health importance in terms of thinking about transmission to other people. So the state decided to do this innovative care plan where they were going to buy people Affordable Care Act plans. They had this great idea, and they thought we should find partners to study it. So we were very fortunate that they came to UVA, and that we helped them study it. And we were actually able to show that people who switched to ACA plans versus just getting medications had better HIV outcomes. So that was a pretty exciting finding. I remember sitting in MR6, finding this out late one night and thinking to myself, this is amazing. And we just discovered this, and no one else knows this, and now we gotta get it out to the world. So that was pretty exciting. And we recently just completed a multi-state project where we actually did the same study, but for a different year, the next year, the second year of the ACA, and looked at it in Virginia, South Carolina, and Nebraska, and found the same thing, which was also very exciting to see it translated to other states. and also took it a step further and decided to calculate a number needed to treat. So we figured this is actually a way that we could really take it to the next step and talk to policymakers. So we're also always thinking about, okay, we have our team of scientists, but how do we get this to the public and what's going to help policy move forward? So we actually found that the number needed to treat was only 20. So if you shift 20 people living with HIV from getting direct medications from the state to getting an ACA plan, we would expect that actually one additional person would achieve viral suppression, which means that there's no HIV in their bloodstream. So they will live longer, and they actually cannot pass HIV along to another partner through sex. So huge, exciting thing that we've been able to do with, a huge team of people. Really takes a big team, and in this case, a multi-state team. And then shifting gears a little bit, thinking about health insurance, and as I mentioned, $40,000 per patient per year for these life-saving medications that help the individual and help public health. We actually were able to get access to all the data about the ACA compliant health plans from a private company through a relationship with a nonprofit in DC called NASDAD. So we got this information about these health insurance plans, terabytes and terabytes of data. And I've been fortunate enough to work with both undergrads and students at the School of Data Science who are getting their master's degree through a capstone project to try to start to make sense of these health insurance plans. We think ACA compliant means that the public is protected, but as you dive into the data about these health insurance plans, you see there's wide variation in cost. How much is the premium? What's the out-of-pocket cost? Is there going to be a prior authorization where a physician actually has to call and argue about why someone needs a specific medication? So we're starting to dive into that data and look at the variation as well as differences in provider networks. We have a very fragmented healthcare system, and these sorts of things about insurance really are starting to impact patients. I think they have been for a long time and have probably been understudied in many different areas. So we're trying to at least shed the light on what's going on with this. How is this impacting people's outcomes and people's quality of life?
Thank you very much. So, Dr. Lewis, you want to
Sure.
talk about what you do, and then we'll...
Yeah, let me introduce myself a little bit. I'm a computational epidemiologist, so mainly take computational approaches to study the spread of disease in populations, and a lot of this is focused using simulation. And I use this a lot mainly to support outbreak response or planning for various infectious diseases. And that can also range from things like natural disasters to pandemics, as well as doing general risk assessments or evaluating policies to doing sort of real-time infectious disease forecasting. And I come from the Biocomplexity Institute. We have a wide range of funding from the classic alphabet soup of federal funders from NIH, NSF, DOD, CDC, and we've even got a little smattering of some private sector from the industry as well, and then a lot of one-offs from other various agencies and departments in the federal government. And our group consists of a wide range of folks. We've got about 50 or so staff and faculty. Sally Kettler is one of the people who will be speaking later on today as well, and she'll probably cover some of this as well. But we range from statisticians, psychologists, epidemiologists, physicists, economists, etc. And mainly the focus, at least in my specific division, is to use simulation to address societal problems. As the epidemiologist, I'm most concerned with disease and its impact in looking at policy from a sort of public health style perspective. Some of the examples of work we've done in the past, I've been involved in over the last couple of years, is forecasting infectious diseases from influenza, Ebola, with the Zika crisis. Everyone wanted to know about whether forecast Zika cases, and even some obscure like neglected tropical diseases like melioidosis, it's a weird soil bacteria in Southeast Asia. We also try and look at things like hurricane response, or because we do have some DoD funding, they're concerned about things like bioterror attacks or even improvised nuclear device attacks here inside the United States. So it's a little afield from infectious diseases, but still the idea of using simulations to make dynamic things that classical style analysis are a little bit more static. And so trying to always bring the data to life. And I think that's where interaction and a partnership with School of Data Science is really exciting for many of my colleagues. We also looked at things like hospital-acquired infection. I'm actually through Giddy. I had met through a brainstorming style session many months ago. Amy Mather, who does some of the infection control work there at the hospital, talking about how we can use modeling and some of the data that she requires to do a better job of some of the antimicrobial stewardship. And then also looking at public health policy, like the distribution of scarce medical resources, vaccinations, and bioterror response plans. I just want to put out there one thing for the data science school to consider, and it's part of the philosophy of why we use simulation, and which often necessitates sort of heavy-duty, high-performance computing style approaches, is that the how things happen is just as much a data element as an observation. So you have your classic data set where you've got columns and observations. It's certainly one way to store data, but then to make it come alive, oftentimes you need to capture that information through either a boring linear computer program or simulation itself, which is just in essence a series of these linear programs. And so the how is really, really important to bring this data to life. And that often allows us to address questions that you can't always observe. Nuclear detonation in Washington, D.C., that's not an experiment we're ever going to run in the real world, right? There's lots of examples of this where it's just either untenable economically, immoral, unethical, but yet these are questions we might want to answer. And so we know how certain things operate. If we can embed that inside of a simulation, combine that with data that's gathered from observations, we can then bring it to life. A lot of the simulations I do are extremely data hungry. We like to do agent-based, very detailed style models. So I'm excited that a lot of the data science techniques, having a school of data science here at UVA will help us a lot with squeezing as much data out, as much knowledge, I guess is really the right way to phrase it, out of the data that we have available, that we can then feed into these models. Because oftentimes I'm presented with like, well, we've got this data set over here, this data set over here, and this one. They're all observed, different frames, different columns in them. A lot of data science techniques can be used to help cluster those and make them more meaningful and thus more uniform for my simulations to then operate on. And so I think this partnership between the style of research I like to do and the School of Data Science is something that's got me very excited. And I think there's also some way that it can work in the other way around. Like a lot of my simulations produce very complex outputs. We try and simulate the society in detail. And so you can imagine, as we all have our smartphones on us and we're gathering all this data, and it's complicated to gather that. In the simulations, you almost produce that same level of detail, except for it's for everyone, and it's not limited to the Android users or to the people who are wearing the smartwatch in this particular study. And so I'm excited to also participate sort of on the post-facto processing of these. And the one thing I think that's useful for a university more broadly is that combination of this how and how to take these observations and make them more meaningful is really useful for collaboration across grounds. There's a lot of departments and a lot of knowledge here, but a lot of it is this sort of how things work kind of knowledge. And so if you take data that people have gathered that is more observational, you have the knowledge of how these systems work, how these processes work, getting those to work together, I think, is really interesting, and that's how you can bring different disciplines together. I've been lucky enough to get a seed grant with the Global Infectious Disease Institute and a fellow researcher over in the Batten School with the Center, David LeBlanc, with the Center of Global Policy. And they're a quantitative discipline, but maybe not quite as crazy quantitative as the School of Data Science style folks. And so this sort of melding where they really understand like what drives people to move around the country, what drives immigration policies and the political atmosphere, the economic atmosphere, which is hard to sort of just capture in raw observations. And so what we're trying to do in our particular project is modeling these complex humanitarian emergencies with a case study on Venezuela and the DRC, Democratic Republic of Congo, and the Ebola outbreak that's going on there. And so generally these are political, economic crises that are also then precipitating health crises. In Venezuela, the government's sort of just not functioning very well. There's public health crisis, people aren't getting vaccinated, they aren't able to care for folks, and so they're getting these sporadic outbreaks of diseases that were well under control before this crisis emerged. And it's also driving people to travel. And people are emigrating lots of places, and some of their neighbors are starting to feel the pressure of that. They're having a lot of refugees. It's hard for them to keep on top of many of the public health concerns that grow from that. And in the DRC side, we've got the Ebola outbreak that's been going on for a long time that's in the milieu of a political, military conflict where people are even weaponizing the vaccines that we now have for Ebola and like attacking people who get vaccinated or trying to prevent certain minority groups from getting the vaccine. And so it gets very complicated. So what we're trying to do is put this all into a model where we can look at events that are not classically thought of as disease events. We normally look at a time series of infections and see if we can forecast that or see if we can do a counterfactual analysis, like if we got this much vaccine into people, how fast would this outbreak then die out? But what we're trying to do is also then fold in observations of political violence in a certain area, healthcare workers being attacked. How does that impact the delivery of that vaccine? And then can we do a better job of forecasting or at least directing aid and helping manage this complex crisis a little bit better? So with that, I think I'll finish and we can let folks start asking questions.
Great, thank you both for speaking. And I think I'd like to pick up a question that I think definitely, well, I know applies to you both. I've had the pleasure of getting to work with Dr. McManus, my students this year. But we're talking about interdisciplinary work, right? And how important that is, and that resonates well here with our group from School of Data Science. And I'm wondering what kinds of hurdles you run into in those efforts. What kinds of things are holding you back that maybe we could all join forces and help overcome? Either.
Sure, I mean, I'll start with that. I think a lot of my experience with this, and I spend a lot of time trying to communicate the results of sometimes these complicated analyses or simulations to decision makers. And that's a cross-disciplinary practice often because these folks are sort of in the political realm or in the military realm. And so they are not classically trained as an epidemiologist nor as a computationally enabled person. And so a lot of it comes down to language for me in my observations. Like what I mean by a model is very different than other people. And these terms just become so overloaded. And you can have like a 20 or 30 minute conversation with someone, you think you're jiving with them, and then all of a sudden they'll say something like, whoa, when you were saying model, you meant that? Like I meant this. And so that's one of the hurdles. And I don't have a perfect solution for that other than just increased engagement. And at least in my world, one of the common things I find simulations are useful for is that it allows you oftentimes to couch the problem the person's facing. You build a representation of it in the computer rather than saying, well, I did this machine learning algorithm and it was able to detect these patterns and therefore you should always do X because 80% of the time that turned out to be the better thing. Sometimes you're able to scaffold the different steps and you have these processes. You say, if you think that this is how this works in this world and then this works off of that, then the conclusion would be under these conditions X. And I think that explanation kind of gets built into these more mechanical, structural kind of processes, which sometimes is lacking when you have a statistical model. So I think oftentimes the marriage of those two things is really a powerful thing.
Yeah, I would say I definitely agree about the language. It's really key, and not only when trying to disseminate, but also when talking within disciplines at UVA. You know, if I'm talking to an economist, we might have some miscommunication unless we get to know each other and really start to understand what each other means. I think on the practical side, something that I've watched over the past few years is trying to understand what each other's priorities are. So priorities, incentives, and making sure the funding actually encourages interdisciplinary work. So I think that the 3 CAPS funding that came out from UVA and Giddy sponsored many projects, I think that was huge because they specifically said people had to be from different disciplines. And I had discussions with different people, but until there's like money behind it, and sometimes it can be tough for people to actually carve out the time to do these projects. So Giddy kind of allowed us to catalyze what had been conversations, turned into projects and turned into abstracts and papers and things like that. I think also talking about what are each person's incentives. So if I have as much protected time as I'm going to have at this point, so I don't need more research dollars to protect my time, but someone else might need research dollars to buy them out of a class to give them the opportunity to do this research. So I think being really open and upfront, at the beginning of a project and talking about what every person's priorities are and what's going to allow each person to participate fully, I think is really important.
I think that's really interesting. I know somebody here from School of Data Science would resonate with that idea of what are our incentives, because they indeed, I think, are different when it comes to the specifics and the practicals, and we have to be very honest about what those are, on the practical level. But at the heart of it, there is some sort of value-driven commonality with those. And so I think that's an important thing to address. I haven't let you speak yet, Doctor, because I'm just wondering if you have anything here or if you'd like to.
Well, I promised I didn't pay these guys incentively to say these things, but you actually both sort of independently hit on, I think, two of the things that Global Infectious Diseases Institute and the other pan-university institutes at UVA, and including the School of Data Science, have been sort of wrestling with, is just that when you're talking with people who are from different disciplines, how do you encourage that conversation, facilitate that conversation, and incentivize it as well? And so I think that the language barrier, just having opportunities, they can be ranging from incredibly informal to more formal, such as this is probably a little bit more of a formal conversation to facilitate those conversations and really call each other out. When you say model, what do you mean by model? Because when I talk to everybody, some people are doing computational models. Other people are physically building models of, wastewater systems, right? And so these are very different when we are saying a platform. What does that really mean? So, keeping each other accountable for our language. But then beyond that, you have the incentivization, and it's been very interesting to me from my vantage point directing the Institute to understand much more across the university about what does it mean to be a faculty member in each school or each entity, and what are your responsibilities and how do you prioritize them? And so I think that actually the one thing I wanted to highlight that's a commonality in your otherwise fairly different research agendas is the goal of really translating what you're getting to the public. So whether it's people living with HIV and improving care for them, or communicating with policymakers, people in whether it's the state government, federal government, about ways to incentivize this, or whether it's stakeholders, CDC, other places who are asking you to do this forecasting of flu and vaccines. And I think that the way to overcome maybe some of these incentivization, if you want to call them barriers or hurdles, and also the conversation issues, is really to, if we all sort of share the same end goal, we want to improve people's lives, in terms of, in this case, infectious diseases care, but you could sort of put it anywhere. I think that that's really where, that sharing that as your eventual end goal helps people come to the table together. And so I think these institutes and other entities and the School of Data Science are opportunities for all of us to sort of identify those sort of global or whatever priorities that can help people start to communicate. So. And they are, but there are significant challenges, and there's significant challenges in an otherwise sort of vertical university structure that we're all still working with to try to overcome. So I personally love your ideas, because we're always trying to make sure that everybody who wants to come to the table can come to the table.
Fantastic. I mean, we have such a great turnout, so I'm sure we have many people that have questions or would like to contribute. So I'd like to just go ahead and start opening this to our group here. Anybody? All of these people are they're speechless. No questions? Yes?
Actually, considering that this is part of the Biomedicine and Medical Center, do you have in mind any way to actually bridging that gap? We are always having a problem on personal behavior between academic and actual clinical side, and sharing the data across the board and then doing the research and still ultimately benefit the clinical care and quality of care for patients.
Yeah, I've thought about this a lot. I think that, I was fortunate to get pulled into the School of Data Science by Giddy, who opened my eyes to some opportunities there. I think we need more liaisons between School of Medicine and all the different schools, including School of Data Science and engineering and everything. I think the more we can have almost like matchmaking by someone who knows kind of the lay of the research, like what's the landscape of research and who should be connected. I think that that's going to be really key. So I think Giddy is doing that. I know Thrive is doing that. And I think we need more institutes that are willing to bridge those gaps and bring people together. I could envision something like the same way the students pick capstones, you could almost have, people from all different schools gather on different topics and try to figure out whose interests align, who share the same bigger goals so that they can work together. Because I think on the clinical side, we have so much data and so many hypotheses and maybe not the time or the expertise to carry out all the research. You should see me sitting there with R. Like, it's not pretty. I try, but my students are so much better at me than me at it. So when one of them has trouble, I try to match them to try to troubleshoot together.
Yeah.
So I think that the want to collaborate is there, and I think we just need more connectors.
Can I ask you a question about this? So I wondered a lot about access to data. So you talk about that there's a lot of data in these, I'm going to use the term repository in the same way you just called out platform, but we have data, and a lot of it is sort of HIPAA protected, behind firewalls and what that. How can we leverage that with these, you have these hypotheses and these questions to ask, and students, whether they're, data science students or maybe medical students who are doing, sort of a summer research project or something like that, or others, how do we ensure that there can be access in a way that's also protective for those individuals? And it could be something within the health system, but it could also be international data sets, WHO data sets or something like that we would like to be able to, or CDC probably has lots of data that they collect through various antimicrobial resistance surveillance and things like that. Is there a good answer to this? Because I don't know.
People that went to the open science data
Yeah.
panel, if any of you came up with good ideas there.
I think we can make it happen. I think that that's primarily an administrative burden in terms of jumping through the hoops to make it happen at UVA. That's been my experience. I have not had a situation where I couldn't get someone access to the right data, but it takes a long time, and it's something that I probably could give to someone else to do, but I don't have someone who does that for me. So I think that it's an administrative burden, because once someone does the ethics training and they're affiliated with UVA, they technically can have access to the data, but it's going to be getting them access to the right computer systems, getting their home computer set up, or figuring out how they're going to come use the computer in my lab. And then I also think that we probably should be using more de-identified data, because de-identified data can be shared more regularly. So once I have all the data from the CDR or from EPIC, all the data that we need for the research question, I could de-identify it and then share it more broadly than I could previously.
So having somebody just on board that specializes in those types of things would facilitate the kinds of things we're talking about.
I think so.
And that could help a lot. Oftentimes when I collaborate with folks, it's, obviously you chime in, but I find that to be the case a lot of the times, that people on the team that want you to do some of this work, they're eager for you to do it, but there is a mechanical process for doing that. And even sometimes when I work with people in government, often just the mechanics of actually copying the file, like some of that kind of stuff.
Yeah.
It is just the nuts and bolts of it sometimes gets down there. So I think.
Right, but the point is it's not trivial.
Yeah.
It is taking your time. It's stressful, and
it's often not funded, right? It's like someone just doing you the favor, and it's like, a couple afternoons of work. It's kind of hard to fit that into your work schedule.
Yeah, time that you could be writing a paper, writing a grant. I actually had a recent experience with government data that we purchased where it got mailed on CD-ROMs in some crazy format, then had to be put into SAS.
Yeah.
I
think I know that day.
Yeah, it was crazy.
all right. So that sounds terrible.
Yeah.
I saw your hand first.
Hi, my name is Gladys. I am actually with Research Computing. So my question for you guys is, thank you for the introduction, it's really fascinating. So in terms of computing resources, what are you guys looking after? How, as a research computing team at UVA, we can actually provide more, the resources that you guys might need?
Hey, that's awesome. There you go. Okay.
I've worked with from ARCS, I've worked with the ARCS folks. There's other research computing folks, but we work a lot with them. We've got access to Grivana quite a bit, but I've been really impressed with the user friendliness of getting onto some of these. And I also attended the HPC's retreat last year, and I thought there was a lot of really good sessions about making it easy for researchers to get onto these HPC resources and tackling some of these problems that, I've got this complicated data set that needs SAS. Like, how am I going to convert this thing? I don't know how SAS works, that kind of stuff. So I found good access to that, at least for myself.
Yeah, I think maybe publicizing more like the things that research computing could do for us. Like maybe if there was someone who could help de-identify data. I previously was using Domino Data Lab. I don't know if anyone else was using that. I found that to be like very easy to use, but then I don't think you'd be able to renew the license. So something like Domino Data Lab, that was really nice because actually it was my understanding was that multiple people could log in and use the same code. So basically, like everybody was sharing the same code and able to do it in a cloud-based environment. I don't know what the current replacement is for that. So I don't know if anyone else in the audience who like Domino Data Lab. I saw some heads. Yeah.
It's a Jupyter Lab.
Okay.
It's kind of the same format, but you use OpenStack software for it now.
Okay.
So if you need help migrating to that, you can help
Okay.
that.
That sounds good.
Mm-hmm.
You said your name was Gladys?
Yeah.
So, I mean, is there a possibility that somebody could be a dedicated scrubber? I've worked with somebody before.
Yeah, so and actually I have to make a disclaimer. I'm new with the team. This is my third week, but I just moved.
Well, you're great.
Thank you. Yeah, I got myself into trouble. I have experience in HPC because I've been at Purdue University before I moved here, and then I know that the different data initiatives that is going around, different campuses, and so what my concern is how we reach the gap, right? How we close that gap between. I know that here at UVA is slightly different because we have the medical side, we have the academic side, how to reach those two to not just to share the data, but how to make the computer resources accessible to both without reaching any complexes. So I think that there is where we have some of the difficulties. I don't know what your question was.
Oh, it was essentially, two people here calling for one of the needs being scrubbing the data, right? De-identifying it so that it can quickly and smoothly be transitioned to someone and shared, right? So we can start learning more. The idea that doing the de-identification yourself it's a little perilous unless you're extremely careful. There should be some sort of protocol there, and that there's no dedicated person to do that. And the question is that even something we could conceive as a possible position?
I think that putting all the resources together and trying to find the different interests from different research groups, that should be something that it should be a possibility.
I would agree that should be a possibility. I think we should talk about it.
Yeah, so I work for Abby. So she planted me here, but I don't know if everybody's familiar with the MIMIC ICU database, which is a publicly available de-identified database that people can develop methods on. And just as an update, we actually the MIMIC people have a program where they reach out to other universities to help them create a de-identified database that's compatible. And this is something that I'm trying to initiate, and I think with if the people who need to put this together, if they see the need of a de-identified database or the expertise to de-identify the database, this would be good for everybody to try to tell everybody that this is something that would be very useful. One thing that they do on this database, which is quite unique, is they not only, it's obvious you can de-identify patient names and dates and things like that, it's not too hard, but they actually figured out a way to de-identify the doctor's notes in a way that I think is somewhat unique. But anyway, I think that the overall goal of having de-identified databases is very important. In fact, another case, I did work with Abby on a capstone project with Justin here, and we actually could have gotten an IRB and had them use the identified database, but identified data, but I actually took the data from the paper was actually de-identified and put on Dataverse, and so it was a publicly available data set, and I think that saved months of headache to get started on it, and I'm a very strong proponent of doing that.
Jack, I think I saw your hand.
I was curious, you want somebody who's a data scrubber, but what do you mean by that? I mean, we're talking about big data and computers. Isn't that not what computers are the best at? Is that we would train them to de-identify data? Perhaps that's sort of a meta challenge.
I was going to say that I would put that at a meta level, and let's talk about.
Because I mean, you're talking about that somebody would have to be knowledgeable enough to go into the record and identify, oh, this is a PHI. I need to take that out. On the other hand, if there are standards in the field, then those standards can say flag that particular field. This is potentially PHI, and a computer could go in and tweak that out. And that would expedite the process of going from the clinical side or the medical side into anonymized land where anybody can get their hands on it. Having a person in the loop is going to be a bottleneck and slow things down. There's an opportunity there, like use standards, develop machines that will go in and do the de-identification for you so that a person doesn't have to. Because otherwise that's kind of a lost cost to you that could be put towards the research.
Will you do that for us, Jack?
So I'll get started right now.
Okay.
So one of the issues there is that the person who does the de-identifying has to be able to look at the PHI.
Yes.
Yeah,
So
that's right.
So you need and you need people with like the clinical understanding to know like which one of these sets of lab values that have 10 different names are actually the same thing. And so I think it is a challenge, but I think it's worth.
It's an enormous challenge. You're absolutely right. Somebody has to look at the PHI in order to be able to tell whether it's PHI. And that's, again, if a computer can do that so that everybody remains blinded, then that's fine. In neuroimaging, my field, the DICOM imaging standard is pretty well understood, and you can go in and just tweak stuff out. If there are standards being utilized for these data types, then that expedites things. If it's free text, like somebody was saying, like, doctors' notes and stuff, that's a different challenge, but perhaps those people who are really good at natural language processing, perhaps that's where you can step forward and really make an impact.
We were very patient.
So I work in UVA on the legal side of this, including data transfers for health data. So, there's a couple issues here. When we think of de-identification, again, that's one of those terms that actually needs some unpacking. Most people think of it as, the identifiers, the name, the medical record number. But there's another category basically of any other information that can be used to identify an individual. And more of health data is falling into that last category because as machine learning and algorithms, everything improve, you can use 3 data points, and if the data set's large enough, you can find, this happened 20 years ago with Bill Weld, the governor of Massachusetts, where they're able to identify instantly where he went to the doctor by those 3 data points. And so that's becoming more and more common. The new regime of data protection laws are basically privacy laws, where the idea of identifiers doesn't even exist. The new privacy law in the EU, the GDPR, doesn't have any concept of identifiers that you can remove. It has the concept of an expert, a person that contemplates, that is certifying that this cannot be, basically as a single individual cannot be identified under these specific circumstances, and then you have to take reasonable efforts to make sure, not that they're not identifiable, there's not an unacceptable risk that they'll be identified. So it's proportional. There's a lot of discretion in there, and that's why you have someone who's basically a data steward who's in charge of sort of qualitative analysis and not just sort of mechanically scrubbing things from it. And that's the direction the U.S. is moving into. We still have sectoral privacy laws. We still have HIPAA talking about identifiers, but if you talk to OCR, every time they get up to the microphone, they talk about how the idea of sort of consent and how the idea of identifiers is getting a little bit outdated, and they're talking about actually thinking about what it means and what that sort of safe harbor of everything else that can be identified looks like. So I mean, in the near future, I think we're going to be in a universe where the idea of identifiers is not really sufficient. Now, it solves a lot of problems if you find a way to, in the GDPR, it's considered anonymized data, which is sort of de-identified, taken to the next level. And that actually frees things up. If you find a way to do that, which a lot of times it's not a process of fixing something on the back end after you create the data set. It's about building privacy in by design and by default so that the output is designed to be something that can be used and have secondary uses. So we have a lot of sort of catching up to do there.
I see. It sounds a little, I feel like it's a bit pessimistic for the future of sharing data. I mean, I understand building things from the front end, but we have a lot that, and, you know, most of our data, right? We didn't do that. We have huge, right? Terabytes of petabytes of data, and we don't have, you know, that protocol, whatever it is a challenge. So, I mean, to me, this sounds very.
There's technologies to fill the gap. I mean, there's ways to do distributed computing, you know, tokenization, day shifting. There's ways to sort of, until we get to that realm where we're thinking of this, that you could take an existing data that said it wasn't designed to be that way, and still use it and sort of have all the statistical validity and utility of it, but sort of use the computing method to get around that.
Can I bring up another point, and I don't, maybe this is not entirely the right venue for it, but I thought a lot about, so we're talking a lot obviously about data and, you know, looking at you know, electronic health records and other places where data are stored. I'm also wondering about access to actual physical data sources like patient biopsies. You know, we have, you know, slides and slides worth of, you know, of samples stored somewhere, hopefully, or, you know, or the, you know, and or, you know, in our case, frozen bacterial or viral samples, that kind of thing. You know, first of all, there's like a data storage, like a storage issue in terms of, and then also access to those things. And then finally, how do we, you know, bring that back to the outcome for, so if it's electronic health record or some other kind of lab test for that individual. So, you know, I'm aware of some academic medical centers where essentially everybody who comes into that place to be treated signs a consent form that basically says we can use whatever we take or collect from you, not take, but collect from you for the research to then translate it back to patient care. And I'm not personally aware of how that conversation is going here. I mean, but in terms, and this is way beyond just infectious diseases, but, you know, there are also, you know, issues in terms of what departments or divisions or whoever it is has access to things, and to these, whether it is the electronic data or actually physical data like that. And so I just something to put out there as well. If we really want to move the needle on you know, patient care and then translating that state of policy. You know, it takes more than any one entity to do that. It would take sort of the will of the entire community. So, you know, I'm not looking back at crime there. I'm not sure if you all have, you know, encountered that, but I think about the CTSA and its goals. Something to discuss, maybe.
Yeah.
Absolutely. I think the issue of that, what you're talking about, the universal consent issues, has been a conversation at UVA for many years, and one that's waxes and wanes. And now with the new changes to the common rule, right, there are even more conversations about that, and how might that be in some ways introduced to our culture here. It would be very different for us, right? If our culture at UVA has generally been very conservative in that area from a compliance perspective in terms of the consent, what that consent might be and what that process might be. So it's an ongoing conversation.
I also think that might be a difficult conversation right now with patients in the community, just given the position we're in terms of the medical center and the billing issues.
Right, where we are right now with our community relationships, that might be some of those conversations are, who gets that consent? You know, is that something that we want the receptionist who's registering the patient to be doing? Is it an iPad that greets you when you come into the clinic? How do we know? There are a lot of issues. It's a great philosophy, and I know I've been to those institutions too where they say, oh yes, everyone here signs a consent for that. Tracking that is really challenging.
Well, I think you've got to be, you've got to be very forward in terms of the benefit to the patient. So, one of my postdocs that I trained went to St. Jude's, and that's a classic place. They've been generating all the genomic data for their pediatric cases, genome data, transcriptome data, proteome, for years. We're not even talking like they just started a month ago or something. They've been doing it for years. And so they fund it. So it's expensive. So if you want to get into like real precision medicine, the patient, I mean, I think you've got to go into it big, which means it's a lot of money, and the patient's got to see the benefit. So I think it's, I mean, to some, and they're creating a complete personalized medicine pipeline. They already have one.
Wow. I actually have a question, and I think somebody here is going to be able to answer it. How fragmented is the storage of data from various departments here? I mean, I know the hospital's running on General Electric, right? GE Centralization. I don't know if we've purchased the storage suite. I was with Philips, right? Research healthcare in my former life. And, Philips had this, I'm not making a pitch here at all. Okay, I promise. But Philips had this, package that they'll sell to you where you can, it's called health suites, and you can store, ridiculous loads of data from across the hospital in one spot. And it's basically hosted on AWS, which makes some people uncomfortable. Do we have anything like that? I'm just wondering, how fragmented is this situation? I don't even know. Does anybody know? You know. So tell us.
Well, we haven't really gone enough for the storage just yet, and I think that you're competing heavily for that. We're trying to figure out how to store this data so that it is accessible and actually useful for everyone.
Okay.
But because of it being a medical center data and that being needed for the research on the academic side, there are competing asks here, and they are mandating us to store the data in one location, which may not necessarily be possible, especially if the data being needed in different formats. So it is a large amount of data here.
Right, and so this is an ongoing discussion. And where are you joining us from? I'm sorry.
I'm data scientist at the medical center, and I have been part of building that data pipeline that is collecting all the data from all the people.
Wow. Wonderful. Thank you. Perfect person to have. Yes.
My name is Steve Patterson. I lead the research and clinical trials analytics team. Organization, the same organization that Valentina is in, but my team supports research, and there's a sister team of mine, clinical analytics, that supports more quality and operational stuff for that.
Okay.
So, I mean, I think one of the biggest challenges is that the data is not centralized right now.
Right.
There's a lot of different pockets of data, and I think I'm sure that I'm kind of preaching to the choir, but traditionally, research data has been decentralized, and each little lab has their own thing. And, one of the big, you can probably speak to more details on it, but from the CTSA grant, I-5 initiative with the development of the commons, is to have some centralization of data that can be shareable and searchable and findable by others. So it kind of centralizes to some extent. It doesn't fix all the problem, right? But it seeks to bring some cohesiveness and some centrality to that.
Yes.
Hi, I'm Vivian Benassi. I used to work with Phil at NIH,
Okay.
so I can address what you just said a little bit. So Phil and I started building the NIH data commons, and there's a couple of people here who's working with it. So we have some problem in NIH. So NIH is made up of 27 different silos, cylinders of excellence. They don't talk to each other. And the premise we have is similar problem as you, right? Each one of the institutes generates a lot of data, biomedical data. And we're storing it in different places. So one of the things we did was realizing that some of the very large data sets do need to be on something like an HPC or a cloud, something there. The reason why is because people would take 40 terabytes of data, move it up to AWS 20 times, and the people making money from it were the cloud providers. And so what we were trying to do was to figure out if there are a collection of data sets that can reside in the cloud so that people could actually share and actually operate over the top of that. So you have the same problem. The commons doesn't solve all problems, but it does create some level of democratization for access to that data. That's one. You raised the issue about de-identified data. I agree with what was going on here. The one additional thing to consider is, and this is what they were currently doing just before I left, is an authentication authorization protocol, right? So are you and are you allowed to use that data? Each one of the cloud providers has some format of that already in place. But what we want to try and do is, what is it the NIH decided it needed to do, rather than what the cloud provider said? Otherwise, how do you even know that Google can see your data, for example? Even if only could. So an authentication authorization protocol is agreed upon, maybe UVA-wide. There are some standards that are starting to come around to choose that, so that it allows you to say, hey, I want to use that data, I want to share it with the other lab. That'll permit you to do that. There are also methods now, they're very good for you, may have a little more knowledge, where there's some work being done on homomorphic encryption, which allows you to search into the data or use algorithms that you don't necessarily penetrate the data, so you don't know all the pieces. To do that, which may be another choice for you. And the flip side of that is, if you only provide your data out to people, sometimes I'm going to want to know that, what data do you have? So I need to be able to see that. So how do I find it? Which is one of the things that Commons is trying to do. You may have de-identified data, but I need to know something about that data set before I'm going to want to use it. So how do you take that information? You can say, you know, gentleman over here, hey, you've got that data set and I can find it, can I talk to you? We agree that it's interesting, and then you go through the computer layer of the authentication authorization that allows me to share everything. And I could be in Australia, for example. You could be here. It doesn't matter. So those are some of the things that she's doing. So to summarize that, you have the same problem as a lot of other groups do, including NIH and some of the other agencies. There are computational methods that you can approach to do this. So don't think that you're not alone. You're not alone. I'm happy to go through. Phil and I know each other quite well. So some of these things I think you could probably lead the way, because in some ways you may have better cohesion than some of the other places, because you have different incentives.
That's phenomenal.
You're not a funding agency, which is an important point before you can align to certain incentives. For example, a patient. You care about, how do I not die, or how do I be less sick, or how do I care for a loved one? That's a very strong motivation to try and bring people together, as opposed to, I've got to get another PDF paper and publish it. And if you survive, great.
Right.
Which is different, isn't it?
Absolutely.
So that's helpful.
That would be extremely helpful, and I think others might want to chat back there, perhaps. That would be an interesting chat that's facilitated by this meeting today. So thank you very much for that. I have to check the time because we've got caught up in. So we actually still have 10 minutes, which I'm very excited about because I think there's still a lot to talk about. And one of the one thing I think is we just had this long conversation that is very exciting. There are clearly a lot of people with similar interests and that have bring different pieces to the table. But we've got some legal information on the table. We have the ones of different groups and departments in healthcare that have this desire to know where the data are and how we can share and how we can access. Do you think anything can come of this meeting where we can actually say we have a little ad hoc group that's going to talk informally? And would anybody do? Is anybody willing to share an email and start a bigger conversation without? I'm not saying we're throwing the. Yeah, we're not going rogue. I'm not, but I'm just curious if we could actually, put our money where our mouth is and actually enjoy some conversation about it.
I can throw out something that you might want to consider since you're talking about funds.
Yeah.
The Research Data Alliance group is now starting to form around what do we mean by a commons, the actual term,
Okay.
and how does it work around the world. And I'm working on it, and there's China, Australia, European, US representation.
Okay.
And that group is starting to form, and if you want to have conversations with them, the group is trying to come up to a better definition of what we mean by that, which covers things like governance, but also the technologies. So don't reinvent the wheel. That's an example. Connect to that group.
Okay.
And what might be some other groups that already exist, so you don't reinvent the wheel. That's just one. There's others as well. In the case of genomic data, there's the GA4GH, the Global Alliance data around genomic data, which is trying to come up with some standards for data. Don't reinvent the wheel on some of the APIs.
Right.
They also have some stuff on security and also some policy. Connecting to those groups and understanding what they're doing, and then figuring out how to apply it to what you have. They're looking for examples. So if you actually have real examples, really interesting to them, you know, just a read. So there's a couple of examples.
Very nice. Thank you again. This wisdom has alighted upon us. I'm wondering if there are any other questions at this point. Maybe specifically regarding, yeah.
I'm going to switch the subject entirely.
Okay.
So I was thinking, the presentations in the beginning about what you all do, it struck me that both of them, to someone coming from the social science, it sounds like social science, that you're doing 50% social science. And I'm wondering, do you think of it that way? And do you have social scientists involved in any of your work? Or, because I think it's like a two-way thing. I think a lot of social science can learn from what you guys are actually learning in the trenches, as it were, for how data plays out within a real, concrete social context, which is the delivery of medicine.
I think that's a really good point, and I think of myself as a social scientist to some degree, and I would advocate that we need to do more of that, and again, I guess part of the point of this, or the organizing principle of this panel slightly, is for these meeting places where folks from more quantitative side, more social side, this concept of like how things happen in these processes and these motivations that are hard to just concretely measure. How do you compute on those? How do you try and quantify those so that you can actually answer questions that require them? I think is, it takes these teams, these cross-disciplinary teams, and oftentimes it takes institutes, these pan-university institutes, to create the space where the conversations can occur, we can agree on these terms and sort of form these multidisciplinary teams. And so, yeah, we've got some people in our group that are a little bit more computationally minded social scientists.
Right. Just as an example, like when you're talking about the distribution of information through a society, and actually this applies interestingly to the data problem we were just describing. Mm-hmm. This is, the basic principle of the sociology of knowledge is that all knowledge is mediated through institutions, mm-hmm. right? There's no such thing as pure knowledge. It's always mediated through institutions. And you see that manifested in how data is distributed. Mm-hmm. So like if you're trying to model that in some way, in your, model the distribution of knowledge or model the flow of a disease through society, one of the things that a social scientist might suggest is that you, in your synapses, as it were, in your networks, weight things by what's called social capital. So there's a whole theory about social capital as a layer of weightings that mediate almost all human interaction. Lots of theorization about it and mm-hmm. so forth. It tends to be lefty kind of stuff. Do you guys incorporate that? Because it might actually help your models, and conversely, you might be able to refute or confirm some ideas that social scientists sort of state on the basis of authority as opposed to having real research behind it.
Yeah, that's a really interesting question. That's an area we've gotten into more and more. I'm not a great authority on it. One of my colleagues, Mark Orr, has spent a lot of time doing that. One of my CDC grants we're currently working on is trying to get into that. Some of that is a little hard to get funded. Oftentimes it's
right.
On the review panels viewed as maybe a little too wishy-washy or not enough actual citations that I can provide that demonstrate that it's useful to answering the questions I'm proposing to answer. But it's not lost on me. Maybe I don't fully appreciate because I've not been able to demonstrate it. It's not lost on me on the importance of that. In public health, we have this sort of interaction a lot. It's like the good of the common, taking away sometimes the rights of the individual for the good of the whole, and that tension's always in there. And yeah, social capital is often the way that's often mediated, and there are marginalized groups that just do not enjoy the same access to health and things of that nature. That's exactly why. And if our models were able to incorporate that better, instead of I think we'd be able to answer these questions better. But again, it's hard to come up with I'm not clever enough to figure out how to get the data quantified on how to measure that all the time.
So what I hear though is that the teams that are formed in both groups don't necessarily involve social scientists, even
I have some examples, yeah. I also think my division, infectious diseases, is very basic science heavy. So if you asked my colleagues, they might call me a social scientist based on just how different my work is than our traditional model. But we do have some very interesting projects. We have one project that's actually funded by an industry partner where we're actually providing telehealth for hepatitis C down in Southwest Virginia, and that the actual care is being funded by Virginia Department of Health. but we built in some qualitative part of the study as well as an anthropologic part of the study. So we have partners in China Shares as our partner on that project.
Oh, China.
And so we have some very exciting, very interesting anthropologic findings coming out of that work on top of the qualitative project that we were able to do. But I agree that sometimes when we try to go to our traditional funders, our peers who are judging our grants don't always see the same value that we might see. So I think we do have to be creative about how we make these projects work, and we're very lucky to get it as part of this industry partner study. So that's one example. And I think most of us are open to those collaborations, and we just need to find the right partners.
Right.
Yeah.
Okay, we have time for one more question.
Yeah, so this one's also going to be a little bit of a twist on what we've been talking about, but most of the talk has been about our data and like the health data and protecting that, or like the issues of sharing that. But is there much within any of your like working groups or fields or anything about bringing in outside data? I asked because a couple of years ago at DSI we had someone from Under Armour come who had just bought MyFitnessPal. I was thinking, oh, well, you have all this nutrition data potentially and all this activity data. What are you doing with that? Oh, I don't know, not marketing. And it's like the people who have potentially rich data sources aren't really using it for much health related. It's for marketing or profit or something. So is there an expected mismatch between people who want to use it for health and the people who have it? So is there anyone trying to bridge those kind of gaps, or just generally looking outside of your own organization for outside data?
I've had pretty good luck with that in terms of I found a partner, NASED, who is a nonprofit, who had a relationship with Vericred, which is a for-profit company, and they have all the health insurance data and they sell it to companies. But they actually had a Robert Wood Johnson grant that stipulated that they needed to share it for free with researchers. So through my nonprofit partner, who already had a relationship with them, we were able to partner and get that data with a data use agreement and certain things in place, but still get that data to use it. And then I've purchased data from the federal government to try to get more national data. Our data is very localized, regional, local, so sometimes when you want to look from a bigger lens, we have done some of that. And then also in infectious diseases, we have a few different partnerships with Virginia Department of Health that give us access to statewide data. So I think we are continually looking out, and if you have other ideas, you should share them with people, because I think people are always looking for those kinds of good opportunities. And I think sometimes the companies that have data might not realize that research could be done on that, or that it would be valuable to researchers, and that they wouldn't have to pay someone to do the research. That the researchers are hungry for data and would be able to, don't need money to also do the research.
Yeah, and I think one of the things that I think Sally Keller is going to hit on a little bit later about public good. I think a lot of these businesses that may have collected this data that could be quite valuable, I think would be very happy to have it demonstrated that this data that they're making a lot of money by doing good marketing on or selling services, monetizing it in various ways, can also have some sort of societal benefit. And I think that'd actually be a very interesting role for pan-university institutes as well as the School of Data Science, sort of being an advocate and figuring out ways in which you can make these partnerships, because like you say, this data is gathered a lot of places. We've partnered lots of people. I'm always thirsting for data. It's always the modeler's common excuse, like, oh, I don't have the data, so I can't do it, or I got this great data set, now I can write my paper, or whatever. It's always the search. But yeah, I think that finding those partnerships would be great.
Great. We've reached our limit. We're gone a little bit over time. So I want to thank all of you for coming.